Hi guys, welcome back. The next topic we're studying is diabetes mellitus, and the importance of this can be gauged from the fact that India happens to be the diabetes capital of the world. So whatever branch that you will specialize in future, this topic would always come up, or patients of this disease would always come up in your practice. More importantly, the incidence of this increase, especially post COVID-19, where your patients will blame you for the same, saying the doctor, you had prescribed steroids, and that is why I developed diabetes mellitus. You see, steroids, high potency ones that were used in COVID, they were used for relatively short duration. So all I can say is majority of these patients were already undiagnosed cases of type 2 diabetes. When they were admitted in a hospital, intensive monitoring was being done for COVID-19. That is when it was picked up that they are diabetic. And since you are technical people, I can explain this to you that type 2 diabetes mellitus would be having a relatively longer incubation period. I mean, the disease could have started in 30s, but maybe the diagnosis will be made in 50s. That's the usual story. And most of these patients of COVID-19 who were diagnosed as suffering from type 2 diabetes mellitus were having pre-existing diabetes. It was just that it was picked up, and they're obviously going to blame us for it. The biggest problem with diabetes mellitus happens to be enhanced cardiovascular mortality. In case if they put up a question one liner, they say, what is the leading cause of death in diabetes mellitus? Then the leading reason should be answered as enhanced cardiovascular mortality. And to explain this, I can give example of Sushma Swaraj ma'am. She was our minister for Ministry of External Affairs in BJP one government. She was a diabetic, and ma'am, being a busy politician, as you know, most diabetics would neglect their health. She suffered from even diabetic nephropathy. She even underwent a kidney transplantation from AIMS Hospital. But since diabetes contributes to enhanced CV mortality, ultimately, ma'am suffered from myocardial infarction, and that was fatal. So why I'm telling you that is, if a person who is a minister, a cabinet rank minister, who's gonna be having all the facilities, and still if MI is gonna occur in that person, it can be so fatal that person would expire. So you can understand from a common person's perspective who would have limited access to medical facilities, the disease can be absolutely fatal. Another example I can give is of Arun Jaitley sir. He was again a minister in BJP one government, and he was a diabetic again. He again developed diabetic nephropathy. Even he had to, go through that process of kidney transplantation. But unfortunately, he also expired. So, I mean, if I can say big leaders who were suffering from diabetes mellitus, and I mean, because they would be having battery of doctors attached to them who would be advising them to do specific steps, or would be advising them to take care of the health. But in spite, because of the busy schedules, etc., that would be a common thing that everybody is going to say to you, that I have a very busy schedule, so I am not able to take care of my health, and therefore enhanced CV mortality can occur. In fact, let me give you an example by describing it even further. This is an old gentleman. He's 70 years of age. His wife had died a couple of years ago, and he stays alone in India. His children are staying abroad in USA. And this man, in morning, he did a WhatsApp video call with his son or daughter, and he was perfectly fine. But in the afternoon, he was found unconscious, unresponsive by the maid. So he was taken to the hospital, where you as a doctor declared him brought dead. And now when the news is being relayed to his son is in a disbelief or shock, and say that I spoke to my dad in the morning, and he was perfectly okay, and he was making plans to go out in the afternoon. And my dad was like retired from the Indian Army. He was very fit. He used to go for a morning walk. He had his breakfast, sir. And now you're telling me he died? So, I mean, most of the time, there can be myocardial infarction in these patients, and it can be silent myocardial infarction, because chest pain may not be perceived by these patients on account of diabetic neuropathy as well. In fact, diabetic neuropathy is one of the leading long-standing complications of the disease. Therefore, the question then arises that should we be trying to control only blood sugar, or should we be aggressively pursuing not only the control of blood sugar, but we should try something to reduce the cardiovascular mortality? Yes, guys, currently we are using anti-diabetic drugs not only for control of diabetes mellitus, but also the same drugs have been shown to improve the stability of the atherosclerotic plaque. Because after all, see, for development of myocardial infarction, atherosclerotic plaque has to tear, as I've explained in cardiology. And that atherosclerotic plaque, the moment it will tear, the platelets will jump in, and that's where the trigger formation or clot formation would be triggered. So I wanna stabilize the atherosclerotic plaque. And please appreciate that the drug that I'm talking at the moment is not statins. I mean, obviously, we need to manage the hyperlipidemia component of these patients in a war footing. So I'll also talk about the cutoffs for LDL values. I mean, less than how much would be recommended for these patients. But at this moment, what I'm talking about is anti-diabetic drugs that have been shown to reduce CV mortality, and that's a hot topic that is being asked nowadays in the current exams. So there are two main drugs or approaches that we can be using to lower CV mortality, and therefore you will notice that in almost every prescription nowadays we are using metformin, which is obviously the first line for type 2 diabetes. Obviously diet control exercise will be told to the patient, but along with metformin, the second drug that is being prescribed is GLP-1 receptor agonist molecules like semaglutide, though they're expensive. But yep, I mean, I can say like this, that money doesn't matter when life is at stake. So GLP-1 receptor agonists have been shown to cause an improvement in the plaque stability and thereby reducing CV mortality. Or instead of semaglutide, another molecule that can be used is SGLT2 inhibitor. From the SGLT2 inhibitor part, that I'll be explaining the mechanism of action of this molecule subsequently. But at this particular point of time, all I can say is that empagliflozin or semaglutide are two attractive approaches that we have available as of now. Semaglutide is available in the injection format that can be given on a weekly basis, and even in the form of oral tablets that can be taken on a regular basis. Semaglutide has a good sugar control. It also helps in decreasing the body weight of a patient, especially American patients or type 2 would be pretty hefty. So weight loss can be achieved with semaglutide. And more importantly, what I am concerned about at the moment is that I want to stabilize the atherosclerotic plaque. So over and above statins, because we've been using statins for so long and still we were losing patients of diabetes due to cardiovascular mortality. So we had to do out of the box thinking, which is why this concept is a must know for you guys, that along with metformin, why are these drugs being prescribed? You are aware of the fact that as far as the most common subtype of diabetes is concerned, it is type 2 diabetes. Just like MODY, maturity onset diabetes or young, is a rare variety, the monogenic variety that I'll speak about. The commonest variety that we encounter is type 2 diabetes mellitus. And why does type 2 diabetes mellitus occur? You see, everybody knows that it is because of resistance. That's not the issue. In the exam, is asking you that why are you getting that receptors to misbehave? I mean, why do you have insulin resistance? Like in this guy at birth, the receptors were behaving just fine. But then maybe in their 30s or 40s or 50s, the diagnosis may be made pretty late in India. But the screening for diabetes mellitus as a process should start according to the American Diabetic Association 2023 guidelines. He says for Asian population, for Indian population, the screening should start as early as 35 years. Yes, guys, earlier the cutoff was 45 years, but the recent guidelines state that the screening for diabetes mellitus in Asian population should start as early as 35 years. And in a person who's having insulin resistance, why is this insulin resistance occurring? In fact, your non-medical patient would be asking you, sir, I mean, why my receptors are misbehaving? Then you will say that this is because of genetic reasons. So polygenetic family history plays an important role in pathogenesis of type 2 diabetes mellitus. So whenever we talk about type 1, there is a insulinopenia, and everybody can answer that leading cause of type 1 diabetes mellitus is autoimmunity or autoimmune destruction of beta cells. I'll jot that down also subsequently. But for the commonest variety of type 2 diabetes mellitus, which presents in adult age group and enhances and leads to cardiometabolic profile of the patient being very risky, even renal failure occurring, diabetic nephropathy occurring. So I had to speak about these drugs, and I had to also speak regarding that why do you have insulin resistance? Then it is mainly polygenetic, multifactorial, and plays a family history plays an important role. Now, as far as insulin resistance is concerned, the question then arises, can we measure this insulin resistance, and can we do some blood test by which we can predict whether somebody will go from pre-diabetes into diabetes? So let's have a look at measures of insulin resistance. Obviously, I'll be talking about how do you identify diabetes and the cutoffs of fasting blood sugar, 2-hour values, HbA1c. So that I'll obviously talk about. But at the moment, since I was talking about type 2 diabetes, the question arises, do we have tests to measure insulin resistance? So I'm not talking about diagnosis of diabetes and fasting and 2-hour value more than how much it should be. I'm talking about tests which are available for insulin resistance per se. And while I give you 5 to 10 seconds to think about it, I'll just zoom into the slide and show you the American Diabetic Association 2023 guidelines. This is a snapshot from the release that they made on their website, which categorically mentions that if a patient is having ASCVD risk, that is atherosclerotic cardiovascular risk, then one of the important drugs that should be prescribed in the patient is GLP-1 receptor agonist, or he says either or SGLT2 inhibitors. So more details from this particular algorithm will follow, but then it is important that we should be knowing the latest guidelines, and that has been a subject of a lot of MCQs in both the NEET PG exam in 2023 and then also the FMG exam. So this is important data that you should be knowing. Now, the question that I asked you was, what test do you do for evaluation of insulin resistance? Because it would be present for a couple of years before the disease strikes. So one of the tests that we have available at the moment is called as HOMA-IR. So, I mean, when you write HOMA-IR, this would tell the laboratory people to do a specific test in which they're going to check out the fasting glucose and the fasting insulin level of the patient. You see, what happens in type 2 diabetes is that receptors are misbehaving, so insulin level values will be elevated. In fact, you're aware in type 2 diabetes, the values of insulin are not normal. The basic fundamental concept behind endocrinology is that if the receptor will misbehave, then the hormone level is not going to be normal. It's going to be increased because hormone is anyway not going to be utilized. So I'll just talk about the cutoffs at the moment, though the cutoffs are not important, but still, HOMA-IR is a test that you'll be writing to identify that a person is having insulin resistance. So the full form of IR is understandable, that is insulin resistance, and HO would be homeostasis model assessment. I'll repeat that again. HOMA-IR, IR stands for insulin resistance, HO stands for homeostasis, and MA stands for the model assessment. So the complete test is HOMA-IR, which would tell you that the person is having or not having an insulin resistance. As far as the formula for that is concerned, that is really not important, but just for the sake of knowledge per se, I mean, what are you going to take into consideration? You're going to take into consideration the fasting glucose, blood glucose values of a patient. Mostly in American books, the values are described in nanomoles per liter, or in Indian setup, it's most of the time milligrams per deciliter. So, I mean, we'll not get into the units per se, but what I'm trying to say is that one of the formulas that you will read is fasting glucose multiplied by fasting insulin, and then the whole thing, the product of it, whatever mathematical value will be coming, the insulin will be in milli international units per liter, and the denominator for this would be 22.5, and the final value that you get here will most of the time in ordinary people be in the range of less than 2, which means that well, the person is not having insulin resistant. It's a wide range dependent on the weight of a person, so I'll not get into the mathematical values there, but generally speaking, you can say lower is the value. Suppose this value is turning out to be less than 1, that means person is pretty safe. If it goes between 1 to 2, that means insulin resistance is beginning to develop, and any value more than 2, I mean, the insulin resistance part is anyway present. You see, insulin resistance is also present in PCOD. A lot of time you would be having a female patient who will come to you and she'll be having acanthosis nigricans. I'll show you the diagram of acanthosis nigricans also, but you are aware from your derma also that acanthosis nigricans would be hyperpigmentation around the neck and in the axilla. And acanthosis nigricans is usually seen in PCOD, or it is seen in type 2 diabetes mellitus, or is seen in metabolic syndrome. So if a person is coming with acanthosis nigricans, HOMA-IR will turn out to be a value usually in excess of 2, which tells you that yes, insulin resistance is present and the patient is at risk for development of type 2 diabetes mellitus. And lots of time in PCOD, metformin is being used. The second test which is available to measure insulin resistance is called as Quickie. And the full form of this would be quantitative insulin. The word is not qualitative, it is quantitative insulin sensitivity. So again, the concept is the same. Insulin sensitivity means the receptor is working, check index. And the third one, that's again a parameter that's called as Matsuda index. Out of the 3 that I've written at the moment, I would like you to remember at least the first one, that is HOMA-IR is a test which can tell about presence of insulin resistance. This is one that is recommended for clinical purposes. There are many others which are available for research-based purposes, so no point of getting into that. But yep, if I get a patient with acanthosis nigricans, PCOD, metabolic syndrome, and I want to demonstrate that yes, there is an insulin resistance, then HOMA-IR will be doing the trick for me. Now coming to the types of diabetes mellitus, the pediatric onset one is called as type 1 diabetes mellitus. Why it occurs? Your answer would be autoimmune destruction of the beta cells. Why are the beta cells being attacked by antibody against self? Well, that is because of HLA association. The autoantibody which is present here is called as anti-islet cell antibody, which will cause destruction of the beta cells. About 80% of the beta cell mass must be destroyed before the manifestations of the disease will start occurring in this child. And once insulinopenia will occur, sugar will not be able to go in the muscles. If sugar cannot go in the muscles, where would the energy come from? Burning of fats, and that's gonna be troublesome because that's where ketones will be generated. So like in a normal person, the cells are utilizing sugar. In the body of a child with type 1 diabetes mellitus, the body is utilizing ketones for energy production. But if the levels of these ketones will rise, that's where triggering or diabetic ketoacidosis can occur. And lots of time diagnosis of type 1 diabetes mellitus is done when the child lands up in intensive care unit with diabetic ketoacidosis. So we'll discuss a case-based scenario for diabetic ketoacidosis subsequently. But at the moment, I'm trying to give you a heads up with respect to why do we have this pediatric onset type 1 diabetes mellitus. It is due to HLA DQA1 associations where antibody, the HLA basically tells us the genetic makeup of this individual is having a problem which is causing antibodies to attack self. In contrast, when it comes to type 2 diabetes mellitus, there would be a relative insulin deficiency. Why I'm calling it a relative insulin deficiency is because, see, in type 1, there is an absolute insulin deficiency, but in type 2, though insulin is elevated in the blood, in spite of that, you will be noticing that insulin will not be able to act. If you do a RIA, radio immunoinsulin levels in patients of type 2 diabetes mellitus in a fasting state, logically your sugar should be low, so insulin production should be shutting down. But in type 2 diabetes mellitus, because of this resistance part, the values of insulin are gonna be found to be elevated. And the reason for this, as I explained even in the previous slide, is defective genes. In fact, it is multifactorial because even obesity will play a role, even metabolic syndrome will play a role. But overall, the single best answer for why do you have type 2 diabetes mellitus would be answered as polygenetic. Then we also have type 1.5 diabetes, which is a subtype of type 1 only, because both will be sharing common etiology. Type 1.5 diabetes is also autoimmune. Type 1 is also autoimmune. But the common thing between the two, when I'm saying 1 and 1.5 is a spectrum, is only from the pathology perspective, because both are going to be autoimmune in etiology. But what is the difference between 1 and 1.5 is type 1 is going to be pediatric onset and 1.5 is going to be adult onset. So the question arises, is it a separate disease because it is presenting in adult? No. All I can say is in type 1 diabetes mellitus, there is a faster destruction of beta cells. So the insulinopenia causes manifestations to usually occur before 10 years of age. If the damage to the beta cells will occur slowly, mark my words there, if the damage to the beta cells will occur slowly, then the presentation of the same patient can be maybe in his 20s as well. So type 1.5 is adult onset presentation of type 1 diabetes only. The only difference is that, age group wise, type 1 will have a faster progression of beta cells. So it usually presentation before 10 years of age or around 10 years of age. And type 1.5 can be presenting in the 20s and 30s as well. So I'll talk about the treatment algorithm for 1.5 as well. But the point is, it is mainly a part of the spectrum of type 1 only. Both are having common thing of insulinopenia. And lot of patients of type 1.5 might be misdiagnosed as type 2 diabetes because type 2 presents in adult age group. So a lot of cases of type 1.5 initially might be misdiagnosed as type 2 diabetes. And that is when we realize that when their glycemic control is not good. And I'll also talk about a couple of hints that could be present that would tell you that this adult is not having type 2 diabetes mellitus. One of the hint would be obviously the presentation would be fairly early, unlike in type 2 where the disease will present in 40s and 50s. If somebody is being diagnosed with diabetes in their 20s or 30s, then 1.5 has to be kept in mind as well. Apart from type 1 and type 2 diabetes mellitus, the third variety is called as gestational diabetes mellitus. For GDM, I would request you to listen to the data from obstetrics and gynecology. It would be beyond the scope of this discussion. And for the fourth variety of diabetes mellitus, well, I can say that would be the special types or the specific types. And by the specific types, I mean that in this case, it would be monogenic in inheritance. By monogenic, I imply one of the specific varieties that I'm going to talk about now will be having an autosomal dominant pattern of inheritance. And you know from genetics that autosomal dominant pattern of inheritance is usually expressed in every generation. So the disease that we'll be focusing on subsequently will also be MODY, that is called as maturity onset diabetes in young. And in this particular case, you will notice more than at least 2 generations It could be even more than two, three, four. Like this guy could be saying, my grandfather had diabetes, my father has diabetes, my father's younger brother has diabetes, his bua also has diabetes. He says diabetes runs in our family. So if you're having at least two consecutive generations getting involved, and specific genetic testing is also available for moody. So this is also an adult onset diabetes. This is relatively moody, I can say, is overall the rarest variety of diabetes mellitus. But then, yep, the genetic testing for the same, which gene is involved, which chromosome is involved, I'll be explaining to you in the subsequent slides. Another reason for development of diabetes mellitus can be damage to the endocrine part of the pancreas. You see, initially the disease will start as exocrine damage and damage to the exocrine component of the pancreas, and then gradually the endocrine part will also get affected. One of the common diseases in which we read about damage to the exocrine component of pancreas is cystic fibrosis. So if you listen to the video in respiratory system, in cystic fibrosis, I've explained that initially the person will be having obviously exocrine component of pancreas getting affected. So amylase, lipase will not be there. That will cause malabsorption. So diarrhea will be occurring, steatorrhea will be occurring in a patient. But as the disease will progress, then even diabetes mellitus manifestations can occur. Another example I can say is chronic pancreatitis, because in chronic pancreatitis, the pancreas mass will basically reduce, and when overall the pancreas mass is being reduced, then the beta cell mass will also reduce, contributing to insulinopenia in these patients. The third reason for the specific types can be various types of endocrinopathies. By endocrinopathies, I imply conditions like acromegaly. Now, you're aware that growth hormone also causes an increase in blood sugar. So, no big deal that in acromegaly patients, if growth hormone levels are supra elevated because the person was not diagnosed, then sugar values fasting can be more than 126, 2-hour value can be more than 200. And you might be thinking he's having diabetes mellitus, but it is because of growth hormone per se. Or another example I can say is catecholamines also cause an increase in the blood sugar. So initially, when a pheochromocytoma patient comes to us with weight loss and his blood sugar is elevated, we might think he's having diabetes, but along with that, he'll also be having palpitations, episodic hypertension, diaphoresis. Obviously, there's specific tests for pheochromocytoma, but what I'm trying to explain is that if growth hormone is elevated, if epinephrine is grossly elevated, if cortisol is grossly elevated, then these patients can also be having fasting blood sugar more than 126 and 2-hour values more than 200 milligram. Then the fourth important reason for this can be drugs. Well, the list of this is fairly extensive, but one of the important ones is steroids. You're aware leading cause of Cushing syndrome is steroids. So steroids on long-term basis, not like for 2 weeks or 3 weeks and you're ending with diabetes, unlikely. But when it's going to be steroids on long-term basis, yes, diabetes mellitus can be a problem. Then mTOR inhibitors again can contribute to it, sirolimus, tacrolimus, calcineurin inhibitors. So I said the list is exhaustive, but the common ones which are used as immunomodulatory drugs can again cause development of diabetes mellitus in a patient. You must never forget what I say next, because thiazides, earlier in JNC 8, we were using thiazides for control of hypertension after 55 years of age. But then we were seeing that with thiazides, gout incidence was on the higher side. And even if you give hydrochlorothiazide to your heart failure patients, you will notice that they were diabetic. Their HbA1c values will be elevated further in spite of they're taking anti-diabetic drugs also. Why? Because of thiazides. Hydrochlorothiazide again contributes to impaired glucose tolerance, impaired fasting glucose. So every time you're prescribing thiazides to your heart failure patients for edema component, wherever possible, we anyway prefer aldosterone antagonists. But if you are using thiazides, you will notice that gradual rise in the value of HbA1c of the patient. Another drug is propranolol. This is commonly prescribed for prophylaxis of migraine and also used for management of patients who are having anxiety, essential tremors. So propranolol can again contribute to increase of HbA1c values and blood sugar, and even antipsychotics per se. So as far as the last three drugs are concerned, I agree that the list is very extensive in pharmacology, but I have mentioned those at the moment which must be known to you from not only the prescription perspective, but overall as a doctor, like, what are the drugs which on long-term basis can trigger development of features of fasting blood glucose going in the diabetic range of 126 and 200 milligram per cent. Now, once we worked out the four varieties, I'll speak more about details of type 1 and type 2 in our subsequent slides. But at the moment, I just wanted to introduce you to the four varieties. And once we've done that, then we'll focus on classic symptoms of diabetes mellitus. Coming to the classic symptoms of diabetes mellitus, because there would be large amount of sugar coming in the urine, this sugar will draw in water and therefore there would be an osmotic diuresis. This will explain the development of polyuria. You see, our proximal converter tubule has ability to reabsorb some of the sugar as well. There's a transporter called as sodium glucose link transporter which can reabsorb sugar also. But if the amount of sugar in the blood is very high, then the amount of sugar in the ultrafiltrate will also be very high and the reabsorptive capacity will be exceeded. This excess sugar in the ultrafiltrate now, where the resorptive capacity is exceeded, will draw in water and therefore osmotic diuresis will be occurring. The definition of polyuria would be urine output approximately double of normal. Normal urine output is 1 ml per kg per hour. That will translate into about 1.5 liters per day. Here this would be 2 times of normal. So polyuria is defined as urine output in excess of double of normal, that is 3 liters per day. Because of this extensive water loss, the patient will also feel extremely thirsty and will drink water again and again. That would be polydipsia. Now, for you as a doctor, every symptom has to be measurable. So, how much amount of water should a person be consuming per day that you will say that, okay, this is polydipsia? Because some people, you see, if they work outdoors, they will anyway be consuming more water. So, the water intake on a daily basis, if it exceeds more than 6 liters per day, that's when we call it polydipsia. So, polyuria, polydipsia are two classic symptoms that we encounter. Apart from this, diabetes is a catabolic process. You see, after all, there is insulin less in the body or it cannot act because the receptor is malfunctioning. As the result of it, there's burning of fats in the body and therefore, and even muscle wasting as well. So weight loss is a predominant symptom. Now, point number 4 that I'm writing will actually be a dummy choice in the MCQ because he will also use the word polyphagia. You would have seen diabetics saying that, I used to eat 1 bowl of rice at lunch and now I eat 2 bowls, but I don't feel full. Or he might be saying, I used to eat 3 chapatis at lunch, now I eat 4 chapatis or 5, but I don't feel full. So polyphagia is also a symptom that we encounter. But the point is, you can quantify urine output. You can quantify water intake, you can quantify weight loss, but you can't quantify how much food somebody is eating. I mean, the size of the plate will be varying, the size of serving will be varying. Somebody will be eating with a small spoon, somebody will be eating with a big spoon, somebody would be eating with a hand. So polyphagia cannot be quantified, and therefore the question that will come on this particular slide or the particular aspect that we're discussing will say, which of the following is not a classic symptom that is encountered in patients of diabetes mellitus? Your answer would be 1, 2 and 3 are classic symptoms, but not a classic symptom is polyphagia. And the logic behind why are we saying that polyphagia is not a classic symptom is because this is not measurable. You see, in earlier times when I was a student, we always used to be taught that the classic symptom of diabetes is polyuria, polydipsia and polyphagia. But now polyphagia is not included in the list. The primary reason for the same that as a doctor I said every symptom has to be measurable, and currently as far as 1, 2 and 3 are concerned, we can quantify them, we can measure them, but point number 4 cannot be quantified. Therefore, on the basis of this background information, what I can say is that if the person is having presence of symptoms, what I mean by symptoms are the ones that I enumerated in the previous slide. If a person is having symptoms of hyperglycemia, then can random blood sugar be useful for diagnosis of diabetes mellitus? Then the answer is a yes. In fact, the surprising data that I would like to say, surprising if you have not listened to the data of diabetes mellitus carefully, is that which value is not useful for diagnosis of diabetes mellitus, then random sugar is useful. You will answer postprandial value. Yes, it looks very shocking. Postprandial value is not useful for diagnosis of diabetes because when I say postprandial, that means person has consumed food, but I don't know how much food has he consumed. In fact, somebody, if he is afraid of the diagnosis of diabetes mellitus, he may deliberately be consuming lesser amount of food for past few days and may not eat food when he comes to the lab, though he might be claiming that he consumed food. That is why we'll be talking about oral glucose tolerance test for diagnosis of diabetes mellitus. But the message is postprandial test is useful for monitoring of diabetes mellitus. It is not useful for diagnosis of diabetes mellitus, but random blood sugar is useful for diagnosis of diabetes. So if a person is having symptoms of hyperglycemia, in fact, sometimes Diabetics might be having excessively high blood sugar values ranging between 600 to 1200 milligram. So in the course of these video lectures, you will also hear me talking about a complication that is by the name of hyperosmolar coma. So there is a possibility that a diabetic can go into hyperglycemic crisis as well without his diabetes being identified. It's only when he's admitted with this hyperosmolar coma that is when the diagnosis will be made. And at that point of time, what you will be doing will be a simple random blood sugar. Random basically indicates that there is no correlation with recent food intake. And if the random blood glucose of a patient is more than 200 milligram per deciliter, then this is diagnostic of diabetes mellitus. So yes, guys, one of the important aspect to be remembered is if person is having symptoms, then random blood sugar is value that are quantified here is sufficient for diagnosis. But a lot of patients who come to us might be asymptomatic as well. Like this 40-year-old man, he came because he says that my father was a diabetic and he was also diagnosed in his early 50s or maybe late 40s. And this asymptomatic individual has today come to me. He's perfectly fine. He says, I don't have any symptoms ranging from polyuria, polydipsia or weight loss. But he says, I want to know whether I'm a diabetic or not. So what I will do in this patient will be a fasting plasma glucose. And in case the value turns out to be more than 126 milligram per deciliter, that implies that that would be a diagnosis of diabetes mellitus. Then I will be making this person consume 75 grams of anhydrous glucose. We do a oral glucose tolerance test where the person will be made to consume 75 gram of anhydrous glucose, and then we will ask the person to sit. We'll tell him, sir, please do not move. You are not allowed to climb stairs, because in these patients, if the person will be climbing stairs, the muscles will be consuming sugar and you will miss out as borderline cases of diabetes mellitus. So no physical activity to be done in the next 2 hours. He just has to sit comfortably reading a magazine. He can scroll through videos in his mobile phone, but physical activity is not to be done. And if the 2-hour value turns out to be more than 200 milligram per deciliter, and we don't even need both of them, if any one of them is elevated, it means that the person is suffering from diabetes mellitus. And sometimes, like if you are preparing for USMLE exam, so you might be having this value determined in millimoles per liter as well. So when it comes to USMLE exams, because in India we use milligram per deciliter, but in Western countries they'll be using millimoles per liter. So that data that I'm saying is only from a Western perspective. 7 and 11.1 millimoles per liter are the cutoffs in Western books. In Indian books, obviously it would be 126 and 200. Now my point is, person will have to spend 2 hours in the laboratory. And nowadays people would be like very time savvy, or I would say person will say, sir, I will not waste 2 hours, or I won't get off from my office for 2 hours. Like he says, okay sir, I'll come at 8 a.m. in the morning after fasting for 8 hours to your hospital and I'm ready for a fasting blood sugar. But then you're asking me to sit for 2 hours in the lab itself, and if I take a 2-hour off from my office will deduct half-day salary. So I cannot afford to spend 2 hours. And like, can you tell me right now whether I'm a diabetic or not? And the patient has come today in the evening. Then I'll not tell him to come tomorrow morning empty stomach and then I'll tell you a diabetic. I mean, if I have all the facilities available, even if a person who came to me today evening, before he coming to me, he went to some restaurant and he had some gulab jamun, or he had cake, or he had a pastry, or he had a dark Belgian chocolate pastry, and he then says, I want to know whether I am a diabetic or not. Then the test that I'll be writing in this patient, as you are aware, will not be affected by recent food intake. HbA1c, as you are aware, is a retrospective test. It gives you estimated average blood sugar value of the previous 8 to 12 weeks. This test is not affected by recent food intake. So the value of this should be more than 6.5%. That is sufficient for diagnosis of diabetes mellitus. And it also says that this should be as per NGSP. That would be National Glycohemoglobin Standardization Program. So that's just the NGSP basically stands for, I'll say that again, National Glycohemoglobin Standardization Program. That's because they're trying to standardize the testing availability for glycosylated hemoglobin. But as you can see from the discussion, random blood sugar is sufficient for diagnosis of diabetes mellitus. And then fasting plasma glucose, 2-hour value, 2-hour PGI. In fact, I can write 2-hour plasma glucose value, and then HbA1c. They're all useful for diagnosis of diabetes mellitus. But what is not useful for diagnosis of diabetes mellitus is the postprandial value. Postprandial value is sufficient for monitoring a case of diabetes. And the reason, as I explained, for postprandial, you will ask the person to go back home and eat his food. And even if he will carry his food, if he eats that food and then he's moving around, or even if per se most people who are afraid to diagnosis or diabetes mellitus would be eating lesser amount of food. You see, if I have to eat in my house and if I have to eat in a lab, then in my house I can eat as much as I want till my stomach is full. But if I have to go to a lab, I'll have to pack some tiffin. And in the morning, if I have to go to a lab at 8 a.m., then I'll pack a small tiffin in which the amount of food that I eat might be lesser than the traditional breakfast that I eat. So person might be eating lesser amount of food, and therefore, I mean, there is no standardization possible. So that is why I said the standardization would mean that you give this guy 75 grams of anhydrous glucose, you're giving a metabolic load to the pancreas and telling the pancreas, okay, neutralize it. And if the pancreas is not able to neutralize it by releasing sufficient amount of insulin, or if the insulin is not able to act, then the values are the ones which would be present. The main crux is, at least from the previous two slides, I've talked about two negative MCQs that will say not a classic symptom of diabetes mellitus, polyphagia, and not useful for diagnosis of diabetes mellitus is postprandial value. Just jot the data down. This is postprandial value is not useful for diagnosis of diabetes mellitus, but random blood sugar in the presence of symptoms is definitely useful. So now we'll be in a comfortable position to work out this slide. What should be the normal fasting plasma glucose values? The answer would be less than 100 milligram per deciliter. Everything that I expressed would be in milligram. In India and America, it is millimoles. And what should be the 2-hour plasma glucose value after consuming 75 gram of glucose? The answer would be less than 140. But you'll be having a lot of patients in your outpatient department who will be having this fasting value between 100 to 125. He will ask you, in fact, he gave this as a one-liner MCQ. He said that you have declared, you are a doctor in the Army Medical Corps, and you have declared a candidate who had cleared the ND exam unfit for recruitment into Army. So his father is arguing with you, like this guy, he got rank 1 in NDA exam, but you had declared him unfit because his fasting blood sugar value was between 100 to 125. Let me say 120. So the question in the exam said, like, as a doctor, what will you write on the case file to label the chap as unfit for recruitment? Then the word that you will write would be impaired fasting glucose. I mean, in English, I can simply say pre-diabetes, but the technical word would be impaired fasting glucose. And I mean, anybody with pre-diabetes cannot be allowed to join a government job, that too a job which requires an extreme level of fitness because of the complications that are associated with the disease and the insurance cost that the government will have to bear for this individual. In contrast, if he says that after drinking 75 gram of glucose, this person was sitting for 2 hours, no physical activity, the pancreas has not met the challenge, and the fasting values between 100 to 125, and in the same patient now the 2-hour values between 140 to 199, and you are declaring that guy is unfit anyway, then you will be writing on the case file impaired glucose tolerance. So the message is that IFG, that is impaired fasting glucose and impaired glucose tolerance. I mean, you can solve that by English also. The person has consumed glucose, so impaired glucose tolerance. When he came to me fasting, then it would be impaired fasting glucose. And well, the amount of fasting that should be minimum present is at least 8 hours. See, over fasting is also not recommended. Like lots of time in India, no, people might be having their dinner at, let me say, 7 p.m. in the evening or 8 p.m. in the evening, and the laboratory opens at 8 o'clock in the morning. So if the fasting will be 12 hour or even extending beyond that due to any reason, then the values might come out to be falsely normal only. That is why HbA1c is considered to be more reliable, because if you do over fasting, then or the person did not have his dinner in the night, or let me say he skipped the dinner or he just had a soup. In those circumstances, if the total amount of caloric intake is being dramatically reduced for past few days before the person goes for a testing, the values of fasting blood sugar might be coming in the normal range as well, which is why HbA1c is overall the best test for diagnosis of diabetes mellitus, because of the fallacies that can be introduced during the testing part. As far as the extreme right hand side is concerned, I think I've lost the count, the number of times this has been asked in your exam. If the fasting value is more than 126 milligram, if the 2-hour value is more than 200 milligram, either of the two, then it is diagnosis of diabetes mellitus. So the extreme right hand side, guys, I mean, as I said right in the beginning, whatever field that you go into in future, diabetic patients would be there in your family, in your relatives, would be coming patients of yours, even in psychiatry would be coming to you and showing you a report, and you have to identify that he is a diabetic or whether he's a pre-diabetic patient. So these terminologies are like anyway important, and because of the fallacies and the inaccuracies that can come, with, let me say, over fasting, or like person climbed a few flight of stairs after consuming this glucose, then the value can turn out to be even within the normal range as well, which is why the test has been designed glycosylated hemoglobin. Glycosylated hemoglobin is preferred because higher is the HbA1c value, more will be the complications that will be seen. So one of the best tests for determining not only the diagnosis of diabetes but the severity of diabetes mellitus is HbA1c. In some MCQs, he might just write the word, which of the following is the best test for long-term control of diabetes mellitus. So whether I'm saying severity of diabetes, whether I say long-term control of diabetes, ultimately it means is the same thing, that higher HbA1c value would mean that the person will be having higher incidence of complications. Overall, as I said, for the 4 MCQs that I've currently jotted on the board before you, severity of diabetes, long-term control, investigational choice for diabetes, best test for diagnosis of diabetes, the answer is HbA1c. This test is a retrospective test. It does not tell you what is the blood sugar today, right now, right here, but it will tell you what is the average blood sugar. So this is a retrospective test. And the beauty of this test is that it is not affected by recent food intake. Like lots of time in India, due to religious reasons, people might be fasting for days altogether. Like lots of time fasting might be for 10 days, or maybe sometimes, in for a month as well. So in some cultures, so retrospective test which is not affected by recent food intake, because if a person is gonna be fasting for long duration, then fasting values can turn out to be normal, but HbA1c will not be affected by it. In fact, this retrospective test will tell you estimated average glucose. EAG talks about estimated average glucose. It tells you average value of previous at least 2 to 3 months, that is 8 to 12 weeks. In a while, also talk about a test for short-term control of diabetes mellitus. But at the moment, what is the meaning of the word long in long-term control is average value for the previous 8 to 12 weeks. Now, how do we calculate this estimated average glucose? A simple hack would be, there are a lot of apps available nowadays, so you don't need to get into the mathematics of it. It is only for your understanding. Nobody will ask you what I'm telling you right now, which is that whatever is the HbA1c value of the patient, if you multiply that by 28.7, and from whatever mathematical value that will come, if you subtract 46.7, that will be an estimated blood glucose. Now, obviously, that mathematics sounds a little complicated, so I'll give you another hack as well. The hack that I'm writing, I will erase in a while. That's an unofficial way of remembering it. Like whatever is the HbA1c value of a patient, like suppose the HbA1c value of the patient is about 8. So you can multiply this by approximately 21, and whatever mathematical value will come here. This 168 is a average value of the blood sugar for the previous 3 months. You see, average is a sum of all values divided by the number of times the testing was done. Average is obviously an accurate value. So what I'm trying to say is, if an average is about, like, let me say 168, 170, that means after eating food, it must be 340. No, that is why the average value is coming this much. So suppose a patient came with a HbA1c of 10%. And he says, sir, what do you mean by 10%? Then all I will do is either I will use the app, or I'll use this mathematical formula, or an unofficial way is multiply 10% by 21. That will mean an average value of 210. If average value is 210, that means after eating food, it must be 400, because average, you see, the average is obviously a sum of all values divided by the number of values. So HbA1c is a retrospective test. It gives the estimated, E stands for estimated, A is average glucose value for the previous 8 to 12 weeks. This is the actual formula. There are hacks also to remember it. Like I mentioned one before you, they will not ask you these mathematical formulas at all. So don't bother about that. There are online calculators available, which we will be using in clinical practice. What you need to remember is the next question that I say. He will say that HbA1c is the best test for diagnosis of diabetes mellitus, but it will be not useful for diagnosis of which variety of diabetes mellitus. Then your answer will be given as bronze diabetes. Now let me give you a quick overview of, what do I mean by the word bronze diabetes? Let me say I have a child who's having thalassemia, and you are aware that children with thalassemia, for their survival, you will have to give packed RBCs to these patients. When you will give packed RBCs to these patients, the RBCs will get destroyed, and therefore the RBCs will liberate iron, and therefore this person will develop secondary hemochromatosis. Because of this secondary hemochromatosis, the excess iron in the body of this patient will attack the pancreas of this patient. And by damaging the pancreas, it will damage the beta cells, and therefore this person will develop insulinopenia. So the message is that people who are treated with packed RBCs in thalassemia, I mean, obviously the treatment of choice for thalassemia is a bone marrow transplantation, allogenic bone marrow transplantation. But for survival, I need to give packed RBC. And if I'm going to give packed RBC, the extra iron in the body will damage the pancreas and will cause type 1 diabetes mellitus. Plus, it will be deposited in the skin. In the bronzing of the skin will occur. That bronzing of the skin is why the name given is bronze diabetes. The term bronze is because there is a bronzing of the skin due to iron getting deposited in the skin, and the excess iron damaging the pancreas is causing development of type 1 diabetes mellitus. Now, all of you are aware of the fact that in thalassemia, hemoglobin A is already less. If you know, in thalassemia there is a hemoglobinopathy, hemoglobin A2 is more, fetal hemoglobin is more, but hemoglobin A is less. Now if hemoglobin A itself is less, HbA1c is formed up of hemoglobin A only. You see, at hemoglobin as a tetraparole ring, and at the first position there is a binding of sugar carbohydrate with one of the tetraparole rings. I mean, every time in our body hemoglobin is being bound by the sugar as well, and sugar, if it is too much, then HbA1c values will rise. But if in the body of somebody HbA1c is already less, then HbA1c cannot be useful for diagnosis of diabetes in that patient. The final summary is HbA1c is overall the best way for diagnosing every variety of diabetes except one, bronze diabetes. Where do you get bronze diabetes? Patients of thalassemia. Why do they develop it? Iron toxicity due to repeated packed RBC transfusion. And since thalassemia is having low HbA1c, the test is not an accurate one. And now I'm going to change the MCQ. Instead of saying what is the best test for long-term control of diabetes mellitus, the question will say which of the following is the best test for short-term control of diabetes mellitus. You can see the change in the language, because every time he was asking about long-term control, severity of diabetes, or investigation of choice for diabetes, students knew that HbA1c is the answer to be given. So the examiner decided to twist the MCQ and change the MCQ. If it says which test is useful for short-term control of diabetes mellitus, then the answer would be given as serum fructosamine. The alternative name for this serum fructosamine is glycated albumin. So if sugar is elevated in the body, it will bind to albumin as well, and the half-life of albumin would be in the range of approximately 2 to 3 weeks. So if he says serum fructosamine will give you an estimated average glucose value of previous how many weeks, then answer is 2 to 3 weeks. I hope you're listening to me carefully. With glycosylated hemoglobin, the estimated average value was for 8 to 12 weeks, whereas currently it would be answered as 2 to 3 weeks. The bottom line, what is happening here is glycation of protein. This time what I'm saying is why this is being formed in the body is because sugar is high. So there is a glycation of protein. Like I was saying, that sugar can bound to hemoglobin and bind to the tetraparole ring of hemoglobin. Similarly, at the moment, albumin is the one which is being bound by sugar. So serum fructosamine / glycated albumin basically means the same, and it is one of the good tests for identifying or quantifying short-term control of diabetes. But if it says long-term control of diabetes, then the standard answer would be given as glycosylated hemoglobin. Next up, I'll be telling you who are the high-risk population for whom the screening for diabetes mellitus evaluation should be done. I mean, the test that we were talking, who are the patients who would be subjected or candidates for the same? Well, any patient who's obese, or especially Asian patients or Indian patients who are overweight. Overweight would mean body mass index of more than 25. Obesity would mean body mass index of more than 30. So you will notice that American patients of type 2 diabetes are anyway obese. But Indian patients may not be obese, but they might be overweight as well, or sometimes having normal weight as well. So don't be under impression that always type 2 diabetes patient is going to be obese only. Even an overweight individual is a candidate who should be subjected to screening for diabetes mellitus. If a patient is having obesity and also having physical activity, he gorges on cheeseburgers and chole bhature, dietary habits are bad, then again a candidate for screening for diabetes. If there's a family history of diabetes, type 2 and MODY have a strong positive family history. In type 2 diabetes, about almost in 50% of cases, person will say that my father or mother is also diabetic. In MODY, up to 90% of cases, positive family history would be present. In fact, in MODY, at least 2 generations can be involved. Then if there's a history of cardiovascular disease, like the person's father had a myocardial infarction, or person's father was had undergone stenting in his coronary arteries or had undergone a coronary artery bypass grafting, then his son also should also be subjected. I'll just tell you in a while what are the Indian guidelines at the moment, at what age should you start screening for diabetes mellitus. But a person of history of cardiovascular disease is a candidate for screening for diabetes, and then would be any hypertensive patient. Well, the cutoff for hypertension as of now is value more than 130 by 80 millimeter of mercury, according to the American Heart Association guidelines. In the Joint National Committee 8 guidelines, it was 140 by 90, but they changed the guidelines in AHA to 130 by 80. So if a person is a hypertensive or is on medication for hypertension, again, he should be subjected for screening for diabetes mellitus. Then you will also check lipid profile. Here we are not talking about only LDL, but we're talking about good cholesterol being lesser and triglycerides being elevated. In fact, this is going to make more sense to you, because if you're going to read about metabolic syndrome, metabolic syndrome is a separate video in the section in cardiology. The alternative name for this is syndrome X. And this is the person who loves to gorge on chole bhature, or I can call him a halwai. That's how literally we call them. Halwai is the person who would be making sweets, and because he gorges on sweets and keep on sitting at one place, he'll have a lot of centripetal obesity, and then the person will also start having hypertension, impaired glucose tolerance, and deranged lipids. So in people who are having metabolic syndrome, you will notice even in the cardiovascular system, I've explained this, that in metabolic syndrome, we don't take into consideration LDL. We take into consideration good cholesterol being lesser and triglycerides being elevated. In fact, this was asked in the recent INICET November 2023 simple MCQ in metabolic syndrome. In the lipid profile, what is the important parameters? It is not LDL, it is deficiency of the good cholesterol and triglycerides being elevated, which increase the risk. And you will notice that in diabetics, the lipid profile will mainly be derangement of triglycerides. Though we'll talk about LDL aspects also, but hypertriglyceridemia again contributes to accelerated atherosclerosis in diabetics, which explains why in the first slide that I talk about sudden cardiac death, and I describe drug approaches which are important to decrease the cardiovascular mortality in these patients. Then insulin resistance is a big time problem in PCOD, or you might be having a male or a female patient coming into your clinic with acanthosis nigricans. So to prove that insulin resistance, obviously you can do a HOMA IR test that I explained to you earlier. But these patients, before you write a HOMA IR test, what test should you write in this patient would be a fasting blood sugar, and then fasting plasma glucose, and then a 2-hour plasma glucose. And if he's not ready for that, then a HbA1c test should be written. So these are patients who are to be subjected to screening. And in the screening, it says if cost is not a consideration, then HbA1c can be used for screening purposes as well. Only the point is, if you're sitting at a smaller center, smaller city where you don't have HbA1c, a person is not ready to pay, then fasting plasma glucose and 2-hour value will do the trick for you. Next, what I say is again important, and I would rate it as an important slide for of this particular discussion. If a patient comes to you, he last year had an impaired glucose tolerance report, or he had an impaired fasting glucose, or his HbA1c was in a range between 5.7 to 6.4. For impaired glucose tolerance, I've already told you the values would be in the range of between 140 to 199 milligram per deciliter. For impaired fasting glucose, the values will be between 100 to 125. All these that I've written in English would be called as pre-diabetes. So if anybody comes to you with this report, then he can convert into diabetes mellitus also. Person is having pre-diabetes, he can get converted into diabetes mellitus. So when should you screen the patient? This time it is screening frequency. These guys are anyway high-risk patients who from pre-diabetes will upgrade to diabetes mellitus. But the message is screening in this patient should be done on yearly basis. Then as far as patients who are having gestational diabetes mellitus, like a young girl at 25 years of age, she was identified as having gestational diabetes, then even she in future can go into type 2 diabetes mellitus. So he says that on a 3 yearly basis, I'll repeat the data once again, in a lady with gestational diabetes mellitus, at least the screening for diabetes on the basis of HbA1c, fasting plasma glucose, whatever is available should be done on a 3 yearly basis on a comparison. And for general population, the American Diabetic Association, that was the point that I was saying, that for general population, the American Diabetic Association 2023 guidelines state that the screening should be starting anytime beyond 35 at and beyond 35 years of age. In the 21st edition of Harrison, he has still mentioned the old data that would be 45 years of age. But if you are stuck in a question where they are asking you on the 88, I mean, he will mention 88, like they have started asking the latest guidelines in NEET PG 2023, then even in NESET November 2023, they mentioned according to the recent guidelines. So since they've stopped and mentioned recent guidelines, word is given in a question, then you should answer according to the latest information, which is for general population. Screening should be done after 35 years of age. In gestational diabetes mellitus, screening should be done every 3 yearly, and then for impaired glucose or impaired fasting glucose, the screening should be done on a yearly basis or an annual basis. And who are the candidates who would be subjected to screening? That halwai, I was saying that person with centripetal obesity, with sedentary lifestyle, is hypertensive, is having evidence of insulin resistance, is having family history of diabetes, family history of cardiovascular disease, or himself is suffering from cardiovascular disease. Like he tells you that I'm already having 2 stents in his heart, or he is having undergone a coronary artery bypass grafting. So when he underwent that CABG, he may not have had diabetes mellitus, but when he comes to you for a follow-up, that is when he could have gone from pre-diabetes to a diabetic situation. And therefore the question also arises, is it possible for you to arrest this conversion of pre-diabetes into diabetes? And more importantly, is it possible that diabetes can exhibit a remission? I mean, lots of time you will see these videos on YouTube which will talk about diabetes reversal, or they will talk about diabetes remission. So I would not like to sound over optimistic and say diabetes type 2 can be reversed, but I can say yes, we do see clinical cases of remission of diabetes mellitus. So it is not a myth, it is a reality that we can have a remission of type 2 diabetes as well. When I say remission, not for type 1, there the beta cells are destroyed, so you can't have a remission with type 1 diabetes mellitus, but remission is definitely possible with type 2 diabetes mellitus. It is not a myth, it is a reality. And what is the definition of this remission? Then HbA1c of your patient would be less than 6.5%. Maybe a diagnosis it was 8%, 9%, but now the HbA1c of the patient is less than 6.5% for consecutively 3 months. So we need to demonstrate this fact that the person has been off medications. This is without the usage. He was maybe on metformin and semaglutide, but now you have discontinued the medicine and still the HbA1c is continuously less than 6.5% for at least 3 months without the usage of oral hypoglycemic agents or insulin. Because in type 2 diabetes also, if HbA1c is very high, initially you start insulin. And in type 2 diabetes mellitus, again, issue is that finally the beta cells will get exhausted. We get a beta cell burnout in type 2 diabetes mellitus in the late phases, and then oral hypoglycemic agents stop working. So we might have to use insulin on those patients as well. Why I'm saying that is because the query of most people is, type 2 diabetes, insulin is elevated, why are you giving insulin? So the guidelines are in type 2 diabetes mellitus, first there is a partial resistance. It's not a complete resistance. So if HbA1c in type 2 diabetes on diagnosis is more than 10%, then we don't start with oral hypoglycemic drugs. If in type 2 diabetes in the MCQ, HbA1c is more than 10%, don't answer oral hypoglycemic drugs, you will start with insulin. And the same patient of type 2 diabetes after 20-25 years can even develop insulinopenia. So insulinopenia is not only found in type 1 diabetes, but is also found in type 2 diabetes in the late phases. But at the moment, I'm not talking about late. I'm talking about early presentation or the initial phase of the disease. Can we have a remission of diabetes? Yes, it is possible. And we do see a lot of cases where human body has great powers of healing. And well, that is the definition that you guys should be remembering. HbA1c value less than 6.5% for 3 consecutive months without oral hypoglycemic agents. Normal value of HbA1c will be defined as less than 5.6%. In fact, this was itself a very funny question that came up. What is normal HB? I think this was FMG exam where they asked normal, and would you believe it? Casually, guys answered 6.5%. Fast reading in an MCQ, everybody answers 6.5. 6.5 is the cutoff for diabetes. No, he asked what is normal. If he said what is the cutoff for diabetes, lots of time, we think that, okay, the question is going to be assuming that because he's asking his HbA1c, that means he's asking what cutoff for diabetes mellitus. So we need to keep a presence of mind in the exam as well. Sometimes, silly questions go wrong. That's normal value was asked. It is less than 5.6%. 5.7 to 6.4 impaired glucose tolerance, though I described multiple definitions of the same as well. And then obviously that million-rupee question is, can we prevent pre-diabetes to go into diabetes? Like a young guy came, his fasting blood sugar is 120. So you had made him unfit for recruitment into army or police or whatsoever or government job. He's saying, sir, I don't want to become a diabetic, so can you prevent this from happening? Then yes, if a person's age group is between 25 to 60, if he's obese, if his fasting plasma glucose is 110, A1C is more than 6%, then in those circumstances, and there's a, if like it's a woman and she's having previous gestational diabetes mellitus, then one drug that has been shown in clinical studies to prevent this conversion is metformin. Apart from metformin, the most important thing, I mean, drug alone will not work. It is lifestyle modification. In lifestyle modification, what will be working is weight loss. We have studied or documented this in clinical studies that the weight loss of a person is more than 7%. He's able to do regular exercise. He's able to do caloric restriction. He stops binging on sweets and avoids trans fats. If the weight loss is more than 7%, it will reduce his CV mortality as well. And the amount of physical activity that is required, I mean, how much exercise should a person be doing? That is light aerobic activity that makes him slightly breathless is 150 minutes of aerobic activity to be done on a weekly basis will be helping in reducing the conversion of pre-diabetes into diabetes mellitus. One more drug, I'm putting a query mark after it to say that some studies have mentioned it. So for exam, the answer is metformin only. For exam, the answer is metformin only, though some drugs have talked about role of pioglitazone as well. But from the exam perspective, don't answer pioglitazone. It is only mentioned in couple of studies. So it is metformin and significant weight loss by light aerobic activity. Do not tell diabetics or pre-diabetic people to do vigorous athletic activity. Vigorous athletic activity can be done in type 1 diabetes, but not in type 2 diabetes because these patients are having atherosclerotic plaques in their coronary arteries. If they're too much vigorous activity if they're doing, then those atherosclerotic plaques can tear and a person can die. And we have seen this in the recent few years. I mean, a lot of videos viral on YouTube where a person is like late 40s, early 50s, he's a diabetic, he's trying to do too much of workout in a gym, he collapses. And when he collapses, he did not even experience chest pain. It was too much of sweating, palpitations, breathing difficulty due to pulmonary edema. And by the time he reached the hospital or before successful CPR could be instituted, the guy was dead. So sudden cardiac death is a big, or increased cardiovascular mortality is a big problem, which is why we are talking about diabetes reversal. We are talking about diabetes remission. I would rate this particular slide as the most controversial slide in the entire app only because there's going to be a lot of ifs and buts with respect to it. But yep, I think this is the basic minimum data that at least a doctor should be available. I mean, this slide is, I would say, very important from exam perspective. But it is important from the perspective of you being a doctor, like an MBBS doctor, because diabetes is so common in India now. So people will ask you, is it possible to have a diabetes reversal? Then I think that instead of saying a reversal, the word that you should be using is a remission. And similarly, can we prevent the conversion of pre-diabetes into diabetes mellitus? Then yes, it is possible with drugs, and obviously a combination of drug and physical activity increment is what is required. It's not only the drug, but from the pharmacological perspective, they ask you to name one drug, then metformin will be doing the trick in this case. You will appreciate why I've repeated this or emphasized this is for CV mortality. I was talking about GLP-1 receptor agonist, or I was talking about SGLT2 inhibitor, but here I'm talking about prevention as compared to cure. Or once the disease has occurred, obviously there are bound to be problems occurring in a patient. And in type 2 diabetes mellitus, one more aspect before I move to the next slide is that if on diagnosis in type 2 diabetes in MCQ, if he mentions that fasting blood glucose of the person is between 250 to 300, HbA1c is 10%, 11%. In those circumstances, because the HbA1c values are grossly elevated, I would not like to start the person on oral hypoglycemic agents, and we should start the person on insulin. That's a separate issue. Indian patient will refuse and he will say, sir, I don't want to do this. I mean, we are okay with it. We can start oral hypoglycemic agents in those circumstances. But in the exam and in real practice perspective, on type 2 diabetes mellitus, on initial presentation, if HbA1c is more than 10%, we go out with all guns blazing. That is, we start with insulin. Now, not to be neglected is another part, that is long-term complications of diabetes mellitus, and the game changer for preventing the long-term complications of diabetes mellitus is now available. This is the sensor that a person can put on his arm, and then we just need to put a scanner over it, and it can tell you a blood sugar right now. I mean, you don't need to go for a capillary blood glucose, because you see most diabetics are very fed up of this fact that every time they have to know their glucose status, you are advising them to prick and then check capillary blood glucose. So an important game changer that I'm telling you at the moment, though I mean this will be expensive, Abbott and so many other companies, I'm not promoting any company in any circumstances, but what I'm trying to say is that continuous glucose monitoring devices are a big time game changer, because if you know that how the blood sugar of your patient is behaving over the entire 24 hours, and not for one day but for weeks and days altogether, then you can program a proper exercise regimen for the patient, proper diet regimen for a person, and more importantly, you can titrate your drug management around that fluctuations of blood sugar so that optimal management can be done. So to prevent these long-term complications of diabetes mellitus, we need to go for strict blood sugar control. But if I straight away tell to patient strict blood sugar control, patient will shake his head and say, yes, sir. But once he goes out, you never know whether strict blood sugar control actually happened or not. The max you can do is scold the patient when he comes back to you after 3 months, 6 months with an elevated HbA1c report. But that's not going to change the things, because this is what happens and has been happening for decades altogether, that patients come back to us, HbA1c is still elevated. We tell them, oh, you should take care of your health. And he says, okay, sir. For a few days he does, and then he forgets about everything. But if a patient is going to be putting up a patch and a device which will do a continuous glucose monitoring, he'll at least scan his values. When you ask him to send these values over to you, you can also monitor him on a daily basis, on a weekly basis, on a monthly basis. And therefore, we can titrate medicines, we can titrate his and modulate his diet plan, we can modulate his exercise regimen to achieve euglycemia. Our objective in diabetes is ultimately to achieve euglycemia, and if we are not able to do that, then the problems that will be anticipated in patients are pretty well known to all of us. We have microvascular complications, we can have macrovascular complications. One of the important microvascular complication that is bound to occur in diabetic patients is diabetic retinopathy. Because of this diabetic retinopathy, though we'll talk more details of it in the subsequent slides, but at this moment, what I want you to remember is neovascularization. You're aware that if a person is having type 1 diabetes mellitus, it will take about 5 years. If person is having type 1 diabetes mellitus, it will take 5 years for development of retinopathy. If a person is having type 2 diabetes mellitus, it will be taking approximately 15 to 20 years for the development of a retinopathy, and that's with poor sugar control. Once there is a new vascularization, there can be a development of retinal detachment in these patients. And apart from retinal detachment, there is always a big time risk of vitreous hemorrhage as well. And the combination of the two will make the person go blind. You see, blindness is a real-time threat in diabetics. That is why I said we are going to discuss it subsequently also when I'm going to talk about laser treatments for these patients. Even in opthal classes, you guys would have read about PRP, pan-retinal photocoagulation. But at this moment, the bottom line is that incidence of blindness in diabetic population can be as much as 25 times higher as compared to normal population. I mean, as compared to you and me, diabetics would be having 25 times higher risk of development of going blind, and which is why HbA1c control is important, because if you do continuous glucose monitoring, HbA1c is bound to remain in normal limits. And apart from diabetic retinopathy, another microvascular complication that comes is diabetic neuropathy. Overall, if he says which is the commonest complication of diabetes mellitus, or if he just says the fact which is the commonest long-term complication of diabetes, it is a neuropathy. And I mean, neuropathy will cause distal sensory loss, due to which person will be having problems with respect to maybe walking on a slippery surface, and more importantly, they might be involvement of unmatted C fibers that will cause pain. A lot of diabetics in your who are your relatives would be telling you that, doctor, I can't sleep at night because I get a pain, or I get a burning sensation in the sole of the foot, because glucose is toxic. It damages the unmelted C fibers, because of which this pain or unpleasant sensation can be developing in the soles of the foot, because of which person will be having an impaired nighttime sleep. Therefore, you'll have to use drugs for management of these patients, which will be discussed in a while. But the message is that diabetes causes development or damage to the small nerve fibers, not the large myelinated nerve fibers. So, vitamin B12 supplementation will not work here. It's the small unmatted nerve fibers that can be damaged, due to which person can suffer from pain, especially a patient can be complaining of pain all the time, and especially it will interfere with sleep. The next complication that I'm telling you will be causing end-stage renal disease. Leading cause of end-stage renal disease in India and America is diabetic nephropathy. And because of this ESRD, the person will be having a requirement of allogenic kidney transplantation. Right in the beginning of this video, I talked about Sushma Swaraj ma'am, I talked about Arun Jaitley sir, both were ministers in the BJP government, BJP one government, and both were diabetic, and both unfortunately expired due to the complications of the disease, and both had undergone a kidney transplantation as well. So allogenic kidney transplantation requirement in India and America is diabetic nephropathy. So these are like three important microvascular complications. And what he can do in a multiple choice question is that he can be comparing these microvascular complications with macrovascular complications. The simple MCQ will say all are microvascular complications in diabetes except, and well, the macrovascular complications are in the form of CAD, which is coronary artery disease, and then is PAD, that is peripheral arterial disease. Because of this coronary artery disease, right in the beginning I mentioned CV mortality is increased. There is an accelerated atherosclerosis that develops in diabetes patients. Because of this accelerated atherosclerosis, they can develop triple vessel disease. They can develop a double vessel disease. For triple vessel disease, we'll be advising a bypass grafting. For double vessel or single vessel disease, we'll have to advise PCIV stenting. You check out in your hospital, majority of patients who are undergoing a cabbage or undergoing a PCIV stenting are actually diabetics only. The mortality rates are increased. Then peripheral arterial disease can occur, and peripheral arterial disease can cause development of arterial ulcers. It can cause development of digital gangrene. The incidence of chances of development of peripheral arterial disease is up to 100 times more as compared to normal population. Again, look at the extreme thing that I'm saying. Diabetics would be having 25 times increased chances of blindness, incidence of blindness, as compared to X means 25 times higher chances of blindness as compared to normal population. And that is itself a question. I mean, which complication in diabetes will be 100 times higher in normal 100 times higher in diabetic in comparison to normal population? Then answer is peripheral arterial disease that can cause digital gangrene. Usually we read about digital gangrene with Burgess disease, that is thromboangiitis obliterans, where we use a Doppler, we check an ankle brachial index, and you read about that in surgery. But diabetes is a cause of development of peripheral arterial disease, and therefore I mentioned a total of five uh, long-term complications in diabetes, three on the left which are microvascular, two on the right which are macro, and the question can be asked as all except, and then he will say which is the best way to reduce the incidence of microvascular complication, and which of the following is the best way to decrease the incidence of macrovascular complication. Must know MCQs for you as a doctor. Best way to reduce the incidence of microvascular complications would be answered as strict HbA1c control. And how do you achieve that HbA1c control strict? We go on a day-to-day basis. You see, like if you have a big task, no, then the big task should be divided into smaller targets, and the targets are daily targets. That if I am achieving euglycemia in the morning and in the afternoon and in the night, then I am right on spot for management. In diabetes, the blood sugar is fluctuating. Suppose it is 120, then it goes up to 220. The complication rate will be more. Suppose there are two patients. In one, the complications are like between the fluctuation is 180 to 220. Average is still 200, 180 to 200. Average is, let me say, 200. But if a sugar fluctuates between 180 to 220, then the complication rates will be lesser as compared to a person in whom the sugar fluctuates between 120 to, let me say, 220. That fluctuations are the main problem, which is why I said the game changer is continuous glucose monitoring. And if we are able to do a continuous glucose monitoring and keep it euglycemic on a daily basis, HbA1c will come under control. Our target will be HbA1c to be going less than 7%. There is type 1 diabetes, then, and there is hypoglycemic episodes also. I will be little more relaxed and I can go up to 7.5. If it's a very frail elderly patient, I can go up to even allow up to 8% because a frail person can't do any exercise, right? Elderly, frail person prone to osteoporotic fractures like a old lady, and she's also bent forward due to old age. I can't ask her to do any kind of exercise. So there, even if HbA1c is up to 8%, I'm okay. But if I'm able to achieve these targets, that means that these complication rates can be substantially reduced. And now he will ask you, what is the best way to reduce macrovascular complication? Do not answer HbA1c. Your answer would be, in this case, strict blood pressure control. I can say 4 hardcore general medicine questions that I would like you to remember at this junction are: 1. Long-term control of diabetes mellitus, HbA1c. Short-term control of diabetes mellitus, serum fructosamine. What is the best way to reduce microvascular complications in diabetes? Strict HbA1c control. What is the best way to reduce macrovascular complications in diabetes mellitus? That is going to be strict blood pressure control. Next up, we talk about etiologies of the various types of diabetes. Initially, I spoke regarding the types of diabetes, right? Type 1, type 2, then MODY and gestational diabetes. But here we'll do a little more detailed analysis regarding why are we having development of these various varieties of diabetes. And type 1 will be having insulinopenia, beta cells would be destroyed. At least more than 80% of the beta cells should be destroyed to cause manifestations to develop in a patient. The leading cause of this is obviously autoimmunity that I'll speak about. But in one of the previous sessions in the exam, a student of mine told me that the question that came to him was fulminant diabetes. I mean, this doctor, he said that he had read about fulminant hepatic failure, but he had not read this term fulminant diabetes. So I did direct him to listen to this video. The fulminant diabetes is a cause of development of type 1 diabetes mellitus, and this is due to a viral insult. Well, the viruses that could be responsible for this can range from Coxsackie bee to mumps to rubella, and mumps usually causes parotitis, but studies have shown that it can cause damage to beta cells, contributing to a absolute insulinopenia. And post this viral insult, in the next couple of months, this child will become diabetic and will suffer from type 1 diabetes mellitus. Obviously, the most common cause is autoimmunity that I will write in a while. But at this moment, I'm trying to focus on those aspects which are relatively less read carefully by us. So you should not only be knowing about the leading cause, but you should also be knowing about bronze diabetes. Bronze diabetes is what we encounter with the patients of thalassemia who have been receiving repeated packed RBC transfusions. There would be an extra iron in the body of these patients. These patients would be having development of secondary hemochromatosis, and due to the secondary hemochromatosis, a triad can be asked on this topic. The extra iron will be damaging the liver of the patient, so there would be cirrhosis. It will damage the beta cells of pancreas, so insulinopenia will cause type 1 diabetes mellitus. And more importantly, it will also, iron will be deposited in the skin, so bronzing of the skin will occur. So 3 organs are getting involved in bronze diabetes: the skin, then the pancreas and the liver. And the reason for all of this is excess of iron in the body. The reason for bronze diabetes would be answered by you in the MCQ as secondary hemochromatosis. We also have a primary hemochromatosis that is discussed separately in the app, but at the moment, secondary hemochromatosis due to repeated packed RBC transfusions is the reason for it. So this usually is seen with thalassemia patients. And then there can be a defective gene also, which could be causing less production of insulin. So the gene which is responsible here is CTL4A gene. So family history can be present in both type 1 and type 2. The percentage of family history association would be lesser. I mean, in type 2 diabetes, more than 50% association with family history can be present. With type 1, family history could be present in less than 15% of the cases. And why I'm saying that is because genes could also be responsible. Now, as far as the most common cause for type 1 diabetes is concerned, well, that is autoimmunity, and the antibodies which are present here are written as anti-ICA, that is anti-islet cell antibody. And the reason why the body is producing antibodies against self is because of a HLA association that you're supposed to remember. The name of this HLA association is HLA-DQ1 O301 and then also O302. So just remember this HLA, because that can be a theory based question, right? HLA association that has increased association with development of type 1 diabetes. This HLA association is the reason why antibodies are being produced against self and is causing a critical decrease in the beta cell mass, resulting in development of type 1 diabetes mellitus. Over and above point number 1 and HLA association, 2, 3, 4 also deserve the respect that they want, in a sense that CTL4A gene has been asked in the exam. The question was simply one liner: CTL4A gene is responsible for development of, answer would be type 1 diabetes mellitus. As far as type 2 diabetes mellitus is concerned, as I explained, this would be polygenetic, it would be multifactorial. Obesity is one of the reasons why you could be having development of type 2, but not all obese people have type 2 diabetes. So be very clear about it. Not all obese individual will suffer from type 2, but obesity predisposes to development of type 2 diabetes. In fact, in type 2 diabetes, due to defective genes, there might be increase in the level of adipokines in the body of these patients. That will explain the exerted atherosclerosis. And due to genetic reasons, adiponectin values in the body of these patients will be reduced. Well, if you read about this adiponectin against adiponectin in pathology, then the patho book will be calling adiponectin as guardian angel against obesity. I mean, we as doctors usually don't believe in angels and God and stuff like that. Obviously, I mean, there is some supreme power that controls everything, but then we are not superstitious. That's what I'm trying to say. And we don't believe in like angels coming and then curing somebody like they do it sometimes, right? Like patients sometimes say God will cure, nature will cure. So, I mean, yeah, there's a supreme power that plays a role. But here, what I'm trying to say is guardian angel against obesity is adiponectin. That is itself a question that prevents us from becoming fat. And because this adiponectin becomes less due to genetic reasons, therefore type 2 will make the person become fat. Look at the surprising thing that I said. I did not say fat person will have type 2, but I said if type 2 person is there, there is a propensity for weight gain in these patients. Insulin is elevated, that again contributes to weight gain, and adiponectin is less, which again predisposes to possibility of development of enhanced insulin resistance in these patients. And all I can say is Western patients, American patients mostly of type 2 will be hefty and big, but most of the time Asian patients or Indian patients may be having normal weight as well. And though, I mean, American patient will be very hefty, that does not mean he'll be having good muscle mass. There is substantial muscle wasting happening in these patients. So type 2 diabetes patient may look apparently healthy in a sense that they're chubby, right? Apparently in a sense that they can be chubby, but they would not be healthy in a real sense, because their muscles are going to be wasted, because diabetes is all about a catabolic process in the body. Now, once we are aware of absolute insulin deficiency of type 1 and relative insulin deficiency of type 2, I said relative because in type 2, actually insulin values are elevated because the receptor is not getting stimulated. Next up is 1.5 diabetes mellitus, which is also written as LADA. Well, the full form of this that will be usually written in MCQs will be latent autoimmune diabetes in adults. From the pathology perspective, as you can see, even in this condition, there is going to be autoimmune destruction of the beta cells. So it will look just like type 1 diabetes only, but it is having an adult presentation. And well, why is it having adult presentation is because the beta cell destruction in this condition is occurring at a slower speed. So it will occur in adults, whereas in type 1, because destruction will be faster, so therefore patient will become symptomatic usually before 10 years of age. Etiology wise, LADA is going to be same as type 1 diabetes, that is autoimmune, but age wise presentation most of the time is like 20 years of age, 30 years of age. So it will be usually like type 2 diabetes. In fact, a lot of these patients will initially be diagnosed as type 2 diabetes mellitus, and only later it will be found that they're suffering from LADA. And well, what test will be positive in these patients would be anti-islet cell antibody, and the name of this antibody would be anti-GAD. I mean, it is unlikely that in the exam he's gonna ask you the term ICA, islet cell antibody, because by English you can solve islet cell antibody. So the term that you need to remember for the exam is GAD, that is glutamic acid decarboxylase antibody, is the villain that causes destruction of beta cells. And these patients are initially diagnosed as type 2 diabetes mellitus, but they do not have obesity. Their C-peptide levels, in fact, are beginning to fall, whereas in type 2 diabetes mellitus, insulin levels would also be in the higher side, and even C-peptide values could be normal or on the higher side. But in these patients, there would be a subsequent insulinopenia. Now, for management of LADA, the treatment will depend upon the C-peptide levels. So, as is mentioned here by the American Diabetes Association guidelines, GADA screening will be useful. These patients are initially misdiagnosed lots of time as type 2 diabetes. And if the value of C-peptide in these patients is less than 0.3, then what are we going to do for this person is treat him by giving insulin, which is same as the treatment for type 1 diabetes mellitus. On the other hand, if he says the value is turning out to be more than 0.7, then we'll be giving metformin for this patient. And a lot of time, initially when they come to us, their C-peptide levels may be more than 0.7 millimoles, and therefore we initially put them on metformin, but then the response to metformin will gradually decrease as the C-peptide levels will fall, and therefore these patients will be migrated from metformin onto insulin. In AHA guidelines, it is mentioned that values between 0.3 to 0.7 of C-peptide is a gray area, where he says that combination of metformin and insulin would be required for the patient. But to keep it simple from the exam perspective, the data to be remembered is type 1 diabetes as insulopenia, use insulin. In LADA also give insulin if C-peptide levels are less than 3. But if he wants to put a twist in the MCQ, what he can mention is that the C-peptide values of the patient is more than 0.7, in which you will be giving metformin for these patients. Now we will focus on another variety that is called as MODY, that is maturity onset diabetes in young. This is a young guy who has been diagnosed as suffering from diabetes. Like, this guy is asymptomatic. I mean, the usual peak age of onset of MODY is usually 25 years of age. This guy is a software professional, and he has got a good recruitment offer from a company in Bengaluru, and the company said that before you join, we would like you to go through an annual medical checkup. And in that annual medical checkup, his fasting blood glucose was coming out to be normally 2-hour value should be 200. Here fasting blood sugar is 200. So he's asking me, doctor, is there anything wrong with the report? And maybe himself got his sugar tested from 2 different labs, and every time the sugar value is grossly elevated. So in this particular person, I will ask him regarding his family history, and the guy will tell me that, yeah, my father is a diabetic, but I never thought that I will become diabetic at 25 years of age. I said, what about your father's brother or father's sister? He says, yeah, my father's brother is also a diabetic. My father's sister is, that is his boy, is also a diabetic. And my grandfather is also a diabetic. Like he says, I never met my grandfather. He died when I was born, maybe sudden death as they explained. But he says that multiple generations in my family are getting affected. That is when the textbook you will read that if greater than 2 generations, autosomal dominant pattern of inheritance is present here. So if he says that in a person diagnosed with diabetes less than 45 years of age, if there's a positive family history in greater than 2 generations with absence of diabetic ketoacidosis, no islet cell antibodies. Islet cell antibodies, if they're present, that will favor a diagnosis as LADA in a patient. Then we have to take into consideration for MODY. And as far as MODY is concerned, guys, it is itself a total of 14 varieties. The total varieties of MODY is 14, out of which the most common variety of MODY would be remembered by you as MODY3. The pattern of inheritance of MODY is autosomal dominant, and the speciality of autosomal dominant conditions is that they are expressed in every generation. Usually the disease will be diagnosed by 25 to about 40 years of age, and most of the time when it comes to the presentation of this particular individual, then the person will not have any symptomatic. He will definitely tell you that his multiple generations have been affected, but person himself will be asymptomatic. Like I said, at least 2 or more consecutive generations are suffering from diabetes mellitus, but this guy is asymptomatic at this particular point of time. As far as MODY3 is concerned, they can also ask you regarding the gene which is responsible for this. So your answer would be HNF1 alpha gene, because genetics is the in thing nowadays. So no big deal that he can ask you the chromosome and the gene involved. The diagnosis of this will obviously be confirmed by genetic testing. I cannot say MODY on clinical grounds. I need to do genetic testing for a specific gene. And if he says what is the first line intervention for this condition, then the first line intervention for this condition would be sulfonylureas. This is the first time that I am talking about sulfonylureas, because see, in type 1 we give insulin, in 1.5 also we give insulin if C-peptide is low. In type 2 we usually start with metformin apart from lifestyle and exercise, etc. But in which MCQ will you say first line intervention would be sulfonylurea is MODY. See, in MODY what basically happens is that there is a defective release of insulin. The beta cell mass in this condition is normal. What is the difference between MODY and type 1 is in type 1 diabetes, beta cell mass will be reduced. But in Modi, the beta cell mass will remain perfectly normal, but because of genetic reasons, the release of insulin is still hampered in this condition. So most of the time in these patients, initially, what happens is that beta cells might still be having some amount of capability to release beta cell. So we'll be using insulin secretagogues, so sulfonylureas would be used. This is the recommendations by International Society for Pediatric and Adolescent Diabetes and even the American Diabetes Association, that sulfonylureas are the initial treatment for this patient. And in case, they are not responding, then later on we can be giving in these patients insulin as well. So insulin is ultimately available for all types of diabetes mellitus, but the main message at the moment is that usually from oral hypoglycemic agent perspective, we start always with metformin in type 2 diabetes. But in which variety would you be starting sulfonylurea on? That is going to be Modi. And sulfonylureas would not be recommended. No sulfonylureas are recommended for management of LADA. There the beta cell mass is critically reduced, so there is no point of beating a tired horse. So sulfonylureas would not be used, and still metformin can be used in case the C-peptide values in these patients are elevated. Let's do a quick summary here, guys, with respect to the 4 varieties that I mentioned. Type 1 diabetes will usually be having a pediatric onset childhood presentation. Type 2 diabetes will be presenting in adult. LADA will again be presenting in adult, and Modi will again be presenting in adult. As far as the etiology is concerned, type 1 diabetes can be autoimmune. It can be due to fulminant diabetes, that is a viral insult. CTL4A gene can be responsible, or bronze diabetes. As far as type 2 diabetes is concerned, the reason would be given as polygenetic or polygenic multifactorial, where adipokines are more, exerted atherosclerosis, adiponectin, the guardian angel against obesity, is lesser. As far as LADA is concerned, this is again autoimmune. It is a subset of type 1 variety from etiology perspective, but presents in adult age group. And then Modi, well, the etiology behind this would be autosomal dominant in inheritance. Family history is positive in type 1 diabetes in less than 50% of cases, but family history is usually positive in type 2 in about 50% of the cases. Then family history is unlikely to be present or rare to be associated with LADA. And for Modi, again, this would be positive family history in 90% cases. Islet cell antibodies will be present in 2 of them, but islet cell antibodies would not be present. Therefore, you can see it's easy to identify type 1 and LADA because both will be having insulinopenia. But in type 2 diabetes mellitus, it's an insulin resistance. In Modi, it is a defective insulin production. Mark my words there. Defective insulin production in spite of normal beta cell mass. Because the beta cell mass is present or beta cell mass will be working, that is why in these patients sulfonylureas have a possibility working, and then we'll be giving insulin for these patients. And for the treatment part, type 1 is insulin. For type 2 diabetes, it is metformin with GLP-1 receptor agonist or SGLT2 inhibitors to improve the cardiorenal outcome of these patients. And for LADA, as I explained, the C-peptide values are less, we'll be using insulin. If they are on the higher side, then we'll be using metformin. And ultimately, these patients are anyway going to deteriorate and will be requiring insulin finally. That's same like in type 2 diabetes, no beta cell exhaustion will occur, so there would be requirement of insulin. So insulin works in all of them. But you need to understand the difference between type 1 and Modi is that type 1, the beta cell mass is reduced, and in Modi, the beta cell mass is normal, yet there is a reduced insulin production due to genetic reasons, because genes also play a role with respect to the release of insulin from the beta cell. So the couple of critical set of enzymes which are missing, which results in Modi manifestation in a patient. So that would be a summary for this particular video.